Welcome, everyone, and thank you for taking time out of your busy schedule to come to the 2021 and beyond updates webinar via Zoom. You already know we're unable to get together quite yet, but I'm with the California Medical Association, and we are still going strong, all right? Today, there's a lot of information. Don't worry, as soon as the presentation is over, we'll put the slides out for you to review. It looks like it's already being recorded, so all of that information is there. Today's presentation includes a lot of information. I've got the Consolidated Appropriations Act, the fee schedule. We're talking about evaluation and management 2021, telehealth response, the quality program payment, that's your APM, alternative payment model, and your Mips is probably what you recognize more than anything else. And then Meridian Compliance as our Medicare contractor for California, Hawaii, and Nevada. You don't have to know everything, you just need to know where to find it, I always say. As I said, I'm Cheryl. I've been with, as a Medicare specialist, more than 20 some odd years, only 29, until it was time to get my COVID shot. And then I fessed up to my real age, okay? I'm part of the Center for Economic Services. We take the noise out of the system. We are there to provide one-on-one assistance to more than 50,000 members on their reimbursement practice. We've even got the general counsel as part of our team. My colleagues all handle health insurance in general, from the Medi-Cal director to all of the things that we put out on the website, Bill 890, physician advocate in training now to help with vaccines. So just about everything that you can imagine. And we try to intervene with the payers and the regulators on the physician's behalf. So we always talk about, before you write it off or just, throw up your hands completely, call us and see if we've got some information and some assistance to provide. As I said, we're 50,000, about 50,000 members strong. The California Medical Association has all of the benefits that we just talked about a minute ago. We've got the legal library. We've got resources that you can get on a monthly basis through the e-bulletin. I know by now you've been at home, some of you, and you're sick of reading everything online, but the only way to learn last year, you saw, was to really keep up with a lot of the changes, and they came out very quickly and at a rapid pace online. So you had to line up some way to get all of your resources, your changes, your frequently asked questions. And so we were a big part of that as the association. We've got our telehealth guide, we've got a financial assistance guide, we have webinars, we even had a 12-part series on telehealth that we just completed. So we've tried to keep everything in the forefront. Here's just a snapshot of the webpage where we deliver on all of that information. The fee schedule, as you already know, usually comes out at the end of the year. This time, taking into account that COVID was still in full effect, the fee schedule actually came out in December, when it usually comes out about the end of October or the beginning of November. And one of the largest issues with the fee schedule when it first came out was that there was a significant decrease in that conversion factor. Remember, the conversion factor is multiplied times the relative value used to give you your update in your fee schedule. That's just a basic. But in 2,165 pages, there were a lot of policy changes, telehealth, evaluation and management coding, as we've said, scope of practice, related issues, principal care management in rural health, opioid use disorder, substance abuse. You've heard that from probably, this is the third year where they've been working and putting in a lot of money into trying to slow down the opioid addiction, quality payment updates. There was something in just about all of those 2,165 pages for everyone. Here on at the bottom of the slide, I give you the fact sheet. Now, of course, we'll talk about the update in just a minute, but in order to know where you're going, you have to know where you've been. And I know you didn't have time to read 2,165 pages. So I gave you probably about 28 pages or so that kind of summarized everything that was going on with the fee schedule. But before the ink was dry on that one, you know, the association, AMA, all of your special societies as well were fighting the fact that there was such a large increase across the board in the fee schedule and therefore the resulting allowances. So everybody was like, look, we're not taking that. And so modified legislation came at the end of December. So right before we went into the new year, there was new legislation in the Consolidated Appropriations Act of 2021, or you'll continue to hear it called about a 1.4 trillion omnibus spending. So this is the one that you'll hear called as stimulus by a lot of your news anchors and whatever. But the bottom line is all we were concerned about was it recalculated the conversion factor and it provided for a 3.75% increase in the Medicare physician fee schedule payments, as opposed to as much as 10%, 10.2% across the board. It revised the schedule to about $34.89 as opposed to the 32. And so those payments had to be pulled back from the website at Meridian and readjusted. Also, the Consolidated Appropriations Act is what continues to suspend the sequestration. Remember, that's that 2% payment adjustment on top of everything else that, of course, we didn't want to hear about in times of COVID. Also, it reinstated the 1% floor on the work gypsy. That's the geographic practice cost index. It's all about the location through to calendar year 2023. And then lastly, the G2211 was an E&M inherit complexity code bundled and not paid until calendar year 2024. And that's because AMA had and CMS had agreed to pay that one, but there were $3 billion that we needed back from that code in order to increase the physician fee schedule. So the bottom line is you've seen all of that, and the Meridian fee schedule was updated to reflect the increases. Remember, your primary care doctors were the ones who were going to see the most positive increases, and then those physicians and providers who do not do office visits were going to see the biggest decreases in their reimbursement. Sequestration, right now they are, let's see, we're on what, the 13th? Okay, so they're in a holding pattern. They were supposed to vote between last night and tonight whether to increase the time period of sequestration. They had already voted yes, but there were two different bills going between the House and the Senate, and they had taken time off, so we had to wait for them to come back in order to vote. So therefore, the claims are in a holding pattern. You already know, though, that after 14 days, they will release. So today will be the ultimate day that, if not voted on, the decision will come forth. Now, I did hear that they were in those last minute arguments, but I didn't see that it had passed. But today should be the day, because CMS is not intending to pay interest on claims they're holding. All right. The opioid treatment program, as we talked about before, new for calendar 2021. So this actually started started to show up in the fee schedule probably about 2018, almost 3 years ago. And so they put forth a lot of monies. You'll see that they've increased the services, counseling, assessments can be done via telephone, of course, because we're in the pandemic and all other requirements must be met. They've got new codes for nasal and injectable naloxone. So, they've got a lot of changes that have been updated. I've got the fact sheet on the billing, coding, and payment indicated on the bottom of the slide. This is as a result of, and at the top of the slide, I've got CR 12161. Anytime you see CR, that means that it's a change request that has come down from CMS with the requirements and the billing instructions. There we are. The resources for all of the information that we have discussed so far, fee schedule. We'll talk about quality payment in just a minute. The updates to the original fee schedule. Meridian is our Medicare contractor. They've had a lot of online education opportunities. So don't forget those. If you haven't already signed up for the listserv, make sure you're included in that. They don't sell your information, but you just want to make sure that you're on top of it. Like we said, you don't have to know everything. You just need to know where to find it. And of course, you want to know what the entity that processes the claims is saying regarding what you should and should not do. I've even seen them trying something new, and that would be a live chat in regards to enrollment. Enrollment is pretty quiet now because there are a lot of flexibilities, but soon it will be alive and back on schedule. The evaluation and management 2021, patients over paperwork. And this is a big initiative by CMS that has a lot to do with decreasing the administrative burden. It's decreasing the need for audits, decreasing unnecessary documentation, ensuring accurate payments while restoring patient care. That's a mouthful because I believe the documentation, the audits will always be with us. They'll just change around what they want you to do and how they want you to do. But I believe it will still be here in by those same names. Remember, Medicare always has a form, and they definitely still audit because it is a federally funded program. We're about 3 months into the first major overhaul of the evaluation and management coding system in probably almost 25 years. We all agree it was time for a change. The existing 1995 and 1997 guidelines are antiquated and did not align with the work that clinicians do. The only thing we have to remember is, though, the outpatient visits have one set of guidelines and your inpatient services have another. But physicians voice concerns over time to complete documentation, spending less time with the patient, and everything else like that. And so, of course, CMS AMA claimed to streamline the time with the patients and decrease that burden. As we were saying just a minute ago, CMS decided to go with the AMA recommendations. These changes include well-defined definitions that depend on the level of medical decision-making in terms of picking your visit, and modifications to the criteria for using total time. Now, in terms of selecting what code that you would like to choose for your services. This one has been a long time coming. Modifications to the criteria, etc. We're not going to, Cheryl is not going to do the whole education piece of this because this is an all-day class. I continue to take them myself, so we're not trying to do that. We're just trying to make sure that you're on the right road I've got some resources to get your questions answered. The Medicare Contractor in the form of Meridian has had a number of sessions in regards to evaluation and management policies that are new for this particular year. So I just want to make sure that we see that change is there. Here I've given you, a glimpse of the medical decision-making table as a key component. Don't forget entirely new guidelines, new code descriptions, all three categories of medical decision-making, one table. Those definitions, like we said, are added. Also, here's one really good update for you that AMA, American Medical Association, had an errata. So, anytime you come up with new guidelines and things that haven't changed in 25 years, everyone's going to be looking closely and asking questions. And so they have clarified a few things here. Reporting a test that's considered but not selected after shared decision making, the definition of analyzed for reporting tests, the definition of a unique test, what is meant by discussion between physicians and other qualified healthcare professionals. You already know that if it's a discussion, it's usually a face-to-face or an interactive encounter. What, something like texting? We consider that a discussion, don't we? Texting back and forth. But sending an email is not considered a discussion, of the interactive type. So they've got some things like that clarified, definition of major versus a minor surgery, and then what activities are not counted with reporting time as your key criterion for the code selection. Here are your time components: minimum time spent on all tasks related to patient care on that day. Remember, it no longer refers to typical time spent, no minimum time for medical decision-making, or more than 50% counseling and coordination has been removed from the descriptions. And now time alone can be the determining factor for the code selection for the 99202 all the way through 992. Oops, looks like I'm missing a number, 99215, but you know that by now. We're 3 months in. And that's just something that we want to remember, or something that I've heard after working with Medicare more than 25 years, when I heard a lot of doctors say, I spent a lot of time with the patient. They're like, okay, we're going to take that into account now. But the thing that you've got to remember is to document it and tell us what that time is. All right. Here's the time range. Remember, typical time used to be an exact time. Now in 2021, it is a time range, whether you've got a new patient E&M or you've got an established patient E&M. Here's some things that time includes: preparing to see the patient, review of the test. So that would be a non-face-to-face. Time does not include, or time does include obtaining the history, exam, caregiver, some of the historian things, ordering medications, tests or procedures, prescription management, referring, documenting clinical information in the record, independently interpreting results. That means if you're not reported separately, it means you didn't charge for that. Communicating results to the patient, family, caregiver, care coordination. All of these things are included. What time does not count is indicated on the slide that's up right now. Of course, time spent for activities normally performed by clinical staff does not count. I heard that on a training just recently. A lot of things I see with the EKG and the x-rays. And don't forget that if you consult your frequently asked questions, CMS, Meridian's got frequently asked questions, your AMA has frequently asked questions. It's something, what you need to know has probably already been asked and answered in some shape or form, all right? So don't forget that. Coding by time documentation. As we talked about earlier, they are trying to alleviate the documentation, but that does not mean that it's going away. And if you know, like I know, most of you have been around for a number of years, and what you know to be true, you are not going to suddenly forget when it comes to processing. You're going to add what they say now to what you already know. The nature of services, I spent an hour on the phone after patient's appointment, is not sufficient. You don't have, the doctor doesn't have to write down the time of each and everything that he does, but you want some type of explanation of definitely what he is in fact doing. The patient's doing good, well done or whatever, then you want to, give an idea of what you looked for and what you looked for in the past visit, and probably what you will be looking for in the next visit. Also, I saw that a lot of providers may want to create a template that they're filling in regarding what their time encompasses. And don't forget, that's considered cloning in a lot of instances when the doctor starts to use the exact same verbiage on each and every patient. That's what they called cloning before. So just be on the lookout for some things like that. All right. Documentation must support the medical necessity spent on patient encounter. That one, two, three, fourth bullet is never going away. Scope of practice, physician supervision. Already don't have to tell you that in the pandemic, we've seen a lot of things, seen a lot of specialists that would never be able to operate on their own. Therapy, everybody, it may be within their scope of practice, but previously, according to the Medicare guidelines, a lot of them were not able to work on their own or incident to, and a lot of flexibility has been built into the program now in order to accommodate access for the patient. And so I have that defined here once again, as well as on this page, as we were saying a minute ago, that medical record documentation for the services is not going away. I think they're just scrambling up some of the guidelines, but here I give you a resource, the change request 11862, and the internet only manual, remember, is what we call the Medicare Bible, because it usually comes up in chapter and verse. And so usually here's where you can make sure you find a lot of your guidelines. The indication probably about a year or so ago regarding not having to regurgitate the documentation all over again, but the doctor could look at it if the ancillary staff has already put it down, etc. He can indicate it's reviewed and signed off that he has seen it and that it is in fact true, instead of having to go through and write the whole thing again. Your resource here at the bottom of the page, don't have to know everything, just need to know where to find it once again in regards to where this come from. The G2212 is the prolonged code. Remember, there was AMA created 99417 for the prolonged services, but CMS did not like that because the 99417 just talked about the prolonged E&M in 15-minute increments. And CMS believed that all of the time needed to be elapsed before they would add on the prolonged time. So Medicare is using the G2212 for prolonged services, and some of your other insurances may be using the 99417. So just make sure you check that out, which code is appropriate for the different insurances you bill. And then I've got a few other guidelines that are added here. And as I said earlier, don't forget Meridian, your Medicare contractor, has ongoing training regarding your E&M billing. And then CMA as well also bought in a coder in the form of Mary Jean Sage. And so we have a 2021 webinar on demand as well, if you need to hear the guidelines once again. There we are. Resources. Don't have to know everything, just need to know where to find it. There's your IOM, your evaluation and management web page. You already know CPT, NCI edits have to do a lot with billing for your visits. And then the AMA page I put down there for evaluation and management. It is worth its weight in gold. The COVID-19 response. I didn't have any I can tell you that if you've got some questions and you want to put them in the chat box as we move along, I am okay with that. Okay. The COVID-19 response, as you already know, we are turning around an entire year on it now, as specified by Section 1834 of the Social Security Act. And you see the 1135 waivers in terms of what locations qualify as telehealth and, you know, just in terms of the pandemic, all of the flexibilities that have been voted on and have been extended. The public health emergency is renewed until April the 21st, 21. So that's coming up pretty quickly. Usually it is renewed in 90-day increments. So we should hear about that one in just a minute. I haven't seen anything yet from our lobbyists and federal legislator. So remember, we said that Congress is back in session this week, and so they should be voting on a lot of this information this week. Keep your eyes and ears open. The Medicare telehealth list, remember that was comes from your final rule. The question that will be answered is what's staying and what's going when pandemic is over. CMS does not have the regulatory authority. The final rule does not make permanent the expansion to telehealth services authorized during the emergency. It just extends those flexibilities. Remember, however, CMS did say, look, we've got some codes that we believe that should stay on the list and they should be covered beyond the end of pandemic. So that would be this slide of what's staying. This next slide here is what's going. These services are on the list through the calendar year in which the pandemic ends. So if they vote to end pandemic anytime this year, by the time we get to December 31st, these services will disappear. If they don't vote to end it until next year, then we would have an entire year where these services would still be covered. So as we say, it doesn't go until the public health emergency is officially declared over. I've got the link to your telehealth list at the bottom of this particular slide. Here's another group of category 3 services that remain on the list through the calendar year in which pandemic ends, all right? Other finalized policy. Telehealth provided by auxiliary personnel when furnished. Incident 2, the audio video technology is used in furnishing a service when the beneficiary and practitioner in the same institutional setting. It's not considered a telehealth and would not be subject to telehealth requirements. Also, the audio only calls, you know, like your 99441, your 99443, those are voted to go. So when so those services that are paying at the crosswalk of the 99212 visits through 99215, those services would be null and void once the pandemic ends. However, CMS says, well, we did have services that had to do with the virtual check-in, if all of you remember, but they weren't paying enough money. $13 to $15 was not what doctors were looking forward to, being paid for a visit on the phone or starting out paying a visit. And the patient was only able to call in. They were not tech savvy. So there was a component missing. Well, CMS has developed a new longer audio virtual check-in that will involve 11 to 20 minutes medical discussion to determine when an inpatient visit is necessary. And like we said, remember, the the current billing is good, but at the end of the year, when all of that go, or not the end of, doesn't have to be the end of the year, but let's say when pandemic is declared over, that's when a lot of the guidelines are going to change, or they're going to require new legislation to continue. You already know there's a lot of we're hearing a lot of information now regarding who is and who is not eligible for the vaccines. Just about everything. Well, we got uh, another day or two. Just about everybody will be there, except for some of our smaller children. 16 and over will be eligible. So COVID vaccines and the therapeutic toolkits have a number of training tools that are out there. The coding. I've got the um, resources for you in terms of vaccine guidance, your CDC toolkit, just about everything that you can imagine. We have it here to make sure that you uh, bill and code appropriately. The vaccine administration, remember with the Biden-Harris administration, effective March 15th, 2021, the vaccine reimbursement even increased. So the vaccine administration even increased to $40 on a national for each dose, where it had been $16.94 and 28. So anything above after March 15th has that increase built in. So it went from what, about $45 to $80, depending on locality. Pfizer, and all of this is in the toolkit, but I just pulled out a couple that are what we like to call pretty much in your face now in terms of the vaccines. Moderna, Janssen, or what we call Johnson and Johnson. I've got an AMA resource for you at the bottom of this page as well. Don't forget, CMA has a toolkit that's updated in regards to the vaccinations as well. Antibody injection and infusion. We've got the coding for you here. Resource at the bottom. Lab codes for you here. Resource at the bottom as well. Don't forget the U005 is your add-on to U003 and 04 when the test is completed within 2 calendar days or less of specimen collection. So that was new for 2021. The rural health flexibilities. I get questions about those, so I make sure that I have a resource for you on this particular page. General COVID resources. The remember we said if you see CR or you see SE means special edition, that 20011 would have been a very specific update that would have come out from CMS regarding the COVID-19 update. Practice specific questions. We've even got an email address. Never had to try that. Most of the 9.5 out of 10 things that we're looking for are probably in frequently asked questions. On the AMA website, we have for our members, of course, we have our liaisons with Meridian as our contractor. I've got my CMS liaisons. So we pretty much have been able to use everything and everybody to get the questions asked, but they do have a very specific email for COVID-19 if there's something you absolutely don't see. AMAs, laboratory billing, frequently asked questions, as we said, Meridian, outreach, just everything that you can imagine. I think we have a resource here for it, and so far it has worked. Look, we've got a couple other hot topics that are out there. Here's a big one. The Accelerated and Advanced Payment Program. Remember, this is the one that came out very early on in COVID. So let's say the end of March. And it was this one was considered a loan that required payment. So this one would have come from Medicare. It would have, the doctors would have applied, but the stipulation was that the monies would be repaid. Originally, when the application was signed, the monies were required to be repaid within 120 days. And then the doctors were like, wait, we're going to need new legislation. 4 months later, our practice has not gotten back to what it used to be. And we simply cannot survive if you are taking back all of the monies owed from the claims that we submit. And so, of course, legislation at the end of last year changed the fact that payment recoupments didn't start until a year after the monies were received. And so here, I remind you, we've turned around on a year. So those docs who got the money in March of 2020, as soon as COVID started, are now, if they have not repaid them already, probably from other loans, then they are coming due. And Medicare would be starting to recoup those monies from the claims that you submit. 25% is automatically recouped for the first 11 months. Also, the remittance advice when you didn't see your money would have that WO, mean withholding effect. So you would automatically see those codes and know where the monies were going. It's being recouped on the accelerated and advanced payment program. At the end of the 11 months, the recoupment increases to 50% for 6 months. And then at the end of 29 months, CMS would send out a letter saying, you still got a few dollars that are owed. What are you going to do with that? If you're unable to pay that, then that's when the interest would start to accrue at 4%. If some of you remember when they first went into effect in this program, the interest was 10.25%, and the doctor's like, we could absolutely positively cannot survive on that. So this program has taken a lot of changes. The one thing that we are looking to change is that the monies do not have to be repaid. And CMS legislation, no one ever agreed that these loans never had to be repaid. So they are still there. For those docs who are still in extreme hardship, when they receive the letters talking about repayment, there is an opportunity to contact Meridian for a case-by-case decision and an extended repayment system that even goes on for 3 to 5 years. But remember, silence is consent. If you don't ask for it, you don't get it, but it is available. Definitely Cheryl has indicated the link to the resource in regards to repayment. But right now, these loans have not been forgiven. They've just been slowed down. The provider relief fund, remember, was the one where it actually did not have to be repaid. It was what we considered, it was what I call the provider stimulus, because these monies were deposited in the physicians who showed that they had serviced Medicare patients in 2018 and 2019. So the HSS looked at the doctor's revenue and automatically deposited 2% into the accounts. If the doctors were active and had been billing for servicing Medicare patients, they would have received the monies automatically. As we say, stimulus money. Here on this particular slide, I remind all of you, if you are connected to the financial assistance in the doctor's office, that these monies need to be spent. There will be times when they may ask for the receipts and how the monies were spent, because it's free money. So they'll remember, we said with federal funds, there's always some type of auditing that's going to go on. So what happens here is anybody that received over 10,000 will be required to submit a report regarding the use of the money. The only thing is they have not submitted what they are looking for in those reports. This particular slide is only reminding providers that they need to sign up in the portal. So that's the intent to report whenever it comes due. That was part of the attestation terms. There was about a 10-page agreement when doctors signed off and agreed to keep the monies and not return them. I've got auditing FAQs, a copy of the terms and conditions if the doctors forgot what they look like. And then I have a phone number for the provider relief line for any questions. And I've tried that line before and people do answer timely. Don't forget the ABN, Advanced Beneficiary Notice of Non-Coverage. Remember, if a service may or may not be covered for the patient's reported condition, that one is still alive and well. What I wanted you to make sure is that when you pull your form out, take it off, make sure you take it off the website, make sure that you've got the most updated copy. It expires June 30th, 2023. So in the left-hand corner of your form, when you have the patient fill it out, make sure that you've got the most valid form. If not, the services have been rendered for free. If you deliver the wrong form, then it is considered invalid. Make sure that it is completed, as we say, only when the services may or may not be covered for the patient's reporting condition. Remember, this is not a blanket form, and don't use it as such. All right. So don't use it on a routine basis. All your patients who come in and they sign off on it. Don't do it. As I said before, I've been with the Medicare program more than 25 years, and it never was intended. It was just to expose the patient to their financial liability for services you know are never covered or may not be covered based on the patient's reported condition. All right. Provider enrollment updates. Here was a big one, because prior to COVID, I think I had a revalidation issue every day of the week until they have authorized the slowdown on this particular regulation. So usually with the revalidations, you have to redo your paperwork, update anything that's gone on in your office within the last 5 years. And a lot of doctors did not receive the notices, or they just had no idea. Maybe they had some other personnel that had worked there. And so a lot of physicians may or may not, their billing privileges may have been suspended because they were not updating the paperwork. Well, that has been relaxed while we're in COVID, but I'm sure as soon as they can, that will be restored. All right. Some of the providers who needed to bill temporarily while we're in COVID were able to get temporary ID numbers. And then at the bottom of the slide, I tell you that there are new provider enrollment administrative action authorities. And what that means in a mouthful is that if they suspend or bar a doctor for any reason, they are making sure that you understand how long that lasts, how, why, and if there's any chance of appealing that particular decision. So they've updated a lot of those guidelines. Also, one thing I want to remind you of is Meridian, of course, is our contractor. And I've noticed that Meridian does something brand new, and they do a chat. So there's an opportunity usually on Monday for you to do a lot of talking to provider enrollment directly. Whereas before you would say, oh, it's taking them too long, I don't hear from anybody. Here now with the chat, they're on live and you're talking to them immediately, okay? So remember, that opportunity is there. Check the education opportunities on the Meridian website. Deep premiums and deductibles for the year. Let's see what else I got. Coding updates. Remember, over 329 editorial changes, ICD-10, a lot of updates in there in regards to COVID. Here are recurring updates. I have this. I didn't try to put these all on individual slides because these are things that updated and continuously occur, usually on a quarterly basis. So I gave you in the left-hand corner the change request CR number where it tells you about the changes. And these are the ones that are effective for April. The quality payment program, remember, is the Medicare Access and Chip Reauthorization Act of 2015, when providers were required to choose the path of an alternative payment model or Mips reporting. It's still going strong, even though we're in COVID. A lot of doctors are like, I don't have time to do all of that while I'm trying to recoup my patients, while I'm trying to do testing, I'm trying to do vaccinations, all of that, please. Well, there are still a lot of probably your more medium-sized practices that are still doing a lot of this, and your larger practices, you know, HMOs, Kaiser, and things like that, that are still have very distinct roles going on in their organizations, they have not slowed. So this program is still alive and well. Here, I just kind of let you know that we're in year 5. The category weights: quality 40%, cost 20, improvement activities 15, promoting interoperability 25. Mips assesses the clinician's performance, as we said, in those 4 categories, and assigns the points up to 100, positive, negatively, or a neutral adjustment. And this particular slide shows what the performance threshold and those payment adjustments are according to the number of points that you receive out of 100. So I have that here. The important dates and deadlines. Most of you know that you've had to be multitaskers because this program does not stop. So 2019's results are reflected in 2021's money. We just finished sending in the doing the reporting for 2020. That just closed on March the 31st, and now we're in 2021, and we will be reporting for performance year 2021 will be reflected in 2023's money. So like I said, you are having to multitask in this particular program without a doubt. The MIPS value pathways. Here on this particular slide, I give you a lot of the highlights regarding what is and is not happening. The fact sheet regarding all of the changes that are going on. There are no changes to who's eligible, what's considered a low volume threshold criteria. I put that here on the bottom. So some of you may work with doctors' offices who aren't even eligible for MIPS, Medicare program, because your physician, if they bill more than 90,000, if they see more than 200 Part B patients, and they provide more than 200 covered professional services, more than likely they are eligible. All right. Let me slide this in there. I don't want to annotate anything. All right, next, there we are. The APM qualifying participant threshold updates. I have those indicated here for you. Oh, I know what I was going to say. On this previous slide at the bottom, that last link, you can input your doctor's MPI number and see if he is eligible for MIPS reporting. Participant thresholds updates. If you're a part of an APM, usually if you're part of an alternative payment model, that means you are doing and operating under the model's guidelines, and how successful you are is already determined by the APM that you are a member of. Here's the resource library. Very good resources. I have doctors who send me emails or call me and ask me for information, and just about everything you could ever imagine you need is in this resource. This is one time that I can say that CMS got it right. It used to put a lot of things out there, and you would go from the top to the bottom of the page, and you never understood what they said. But here, the resource library for QPP is really good. Benchmarks. The service center has people who actually answer the phone. And then at the bottom of the slide, there is even a no-cost technical assistance. The Health Services Advisory Group operates for California, and they even do it for free. They've already been paid by CMS. So if you need some help with your MIPS reporting, you are still a MIPS eligible clinician, they are there. Bill more, somebody did say bill more than 90,000 is this per month. It is that's actually a year. That's 90,000 for the year. So that's not hard to, you have some doctors though who don't have a lot of Medicare, but yes, that would be a year. Remember, your your billing goes on for the year with Medicare. At the end, everything goes on when they do your, they download your claims history for the year. All right. Compliance with our MAC, Medicare Administrative Contractor here. I've got a look at the website. I'm coming on home, where you've got a lot of information there. I've got the link for you. Make sure that you are in the right place for Meridian. We are JEB as in boy. The Meridian Medicare portal, self-service. Remember, they like for you to help yourselves. And sometimes you would like to help yourself as well, because you can operate 24/7. You get up early, you stay up late, you can do a lot of the work online without having to talk to anyone, verify eligibility. Remember when you used to get back the remittance advice and it would tell you somebody wasn't eligible? You're like, no, you're screaming that you've rendered the services for free or you got to catch up with them. Claim status. Print your remittances, reopen claims that you're dissatisfied with, submitted appeal, level 1 through 5. You just not going to take that. Overpayment results. Why do we owe money? I got questions to ask. All right. Satisfied customer. We're on the move. Updated 855B. If you don't use the electronic transaction in what I like to call PECOS, because it decides where you are. In California, we call it PECOS. When Palmetto had the contract and we were in South Carolina, they called it PECOS. So depending on where you are in the region, the CMS E is the form usually for group and some of the other providers. So just want you to make sure that if you're needing to use the paper form as opposed to using the electronic internet application, then make sure that you have the most correct version. 0720 was required as of this year. They no longer take the old versions of that form. Updated electronic transfer as well. Look, 588 form required. This is the one for getting your monies in the bank. Definitely don't want to have issues with your money going to the bank. So they have an updated form on that as well. All right. 2 new codes for prior authorization for certain OPD. That's outpatient department. Everybody, don't tell yourself that these are the physicians. This is the outpatient department at the hospital. But we always put it down because if your patient is working the outpatient department and they are denied for you not having prior authorization for these services, remember, they're going to come back to the provider and ask them, what's the medical necessity? So even though this is not yet your bill, it's the hospital's bill, they're working with you. Matter of fact, I have a doctor who I believe who even worked UCLA, some of those very large groups where UCLA tells the doctor, you put it in. And that way we won't have an issue with looking for it, because if you do it, then you'll do it right. So 2 new services that are added to the prior authorization list for the outpatient department. Targeted probe and educate. This one has been, this is where usually you have to send 20 to 40 medical records. This one, in fact, has been stopped while we're in pandemic, but as soon as it's over, I'm sure Meridian will resume the activities. There you go. 3 rounds of education. They tell you what's wrong with your medical records and expect that you will fix it. All right. Let's see what question I got. Can we submit paper CMS form when Medicare is secondary? If you have a waiver, if you are a provider that is allowed to bill paper, and there are still some who are on paper, then you could do that. If you do not have a waiver to submit paper, then it would bounce back to you. All right. We got that one. Let's see. What's next? Recovery audit contractor. Remember, very big as far as the federally funded program is concerned. They do recoup a lot of the money. They've got approved issues. However, they do tell you where they have recouped the money before. That's the best part of that here. I've got that link that says rackinfo.hms.com. They tell you where they found issues with other providers before. And then they've got frequently asked questions under burden relief. So I have those for you as well. I'll get that other question. And then we're down to the end of my presentation. Let's see if you've got other questions for me. The reimbursement helpline. My contact information is available. As I said before, the presentation, we will be sending it out to you. So definitely you will have your own copy. All right. Did I have any other questions out there? You see any other ones? Nope.
Okay.
Going what? You sure? Going once? Going twice? No?
All right. Well, thank you everyone for joining us. And as Cheryl said, I will send out a copy of the slides to everyone who attended. And if you have any questions, reach out to Cheryl or to the Medical Society. We'll get you those answers.
Absolutely.
All right. Thank you.
All right. Looks like we're ready to go. I got all the questions that were in the Q&A as we went along. You got any questions? Need any assistance? Don't fail to reach out to me. Or if it's not something I specialize in, I definitely have a number of colleagues who do. All right. All right. Thank you again, everyone. I look forward to seeing you when we can jump back out.